Hi, I'm Kathy Andriole from the Department of Radiology at Brigham and Women's Hospital, Harvard Medical School, and the Center for Evidence-Based Imaging. The title of my talk today is Automated Electronic Medical Record Dose History Extraction, Monitoring, and Use. The outline of my talk is what we've done at Brigham and Women's Hospital in terms of automating a dose metric extraction algorithm, assigning the appropriate anatomical region to that dose metric, going further to estimate patient size, which ultimately could give us some information around specific organ dose. And then once we have that information extracted, how do we use that dose information? In particular, we used it to look at the variation in our protocols of our exams and to see if we could improve those. And then I'll summarize and talk about some future activities which include input to computerized physician order entry for decision making at the time and point of order. The algorithms I'm going to talk about for automated dose extraction here are algorithms that have been worked on largely by Drs. Aaron Sodikson and our fellows Dr. Graham Warden, Ichiro Ikuto, and Luciano Prevedello. What we did was create an algorithm that extracts CT dose index metrics from our electronic medical record. We've automated this algorithm, assigned anatomical region, estimated patient size, and then created some business analytics tools to examine our protocol variation. So our automated dose metric extraction takes from the electronic medical record dose screen our existing archive and extracts volume CT dose information, or CTDI vol, and dose length product, or DLP. We use an optical character recognition tool that is open source. We used Dr. David Clooney's tool from his DICOM website, but there are other tools available that enable you to screen scrape from dose report screens the information that we need, in particular CTDI vol and DLP. We also captured our table start and stop positions, and using DICOM attributes we assign, and protocol and series name, we assign body part. We've made our tools open source as well. This is an example of one of our dose screens where you can see CTDI vol and DLP in the red boxes here, and the optical character recognition will search for this and get us a value. Here's another example of another manufacturer, and you can see there is quite a variety, and the formatting differs here. We can also see that there's CTDI vol and DLP reported for each event of a dose encounter, and you can see some series description as well. Here's yet another dose screen from a third manufacturer, and in this particular manufacturer stores the dose report content in its DICOM attributes of the DICOM header. It's using radiation dose structure report, which has been a standard since 2007. Now, not all CT manufacturers use this, but when they do, it makes extraction of dose information much easier. We created our algorithm and then validated this looking at our CT examinations that were done at Brigham and Women's Hospital from between 2000 and 2010. This gave us a cohort of 54,000 CT encounters. A little less than 30,000 of these actually had dose screens associated with those examinations. We took from that cohort and randomly selected 150 encounters for each of our major CT scanner manufacturers to validate our algorithm. We manually checked against that, and we found that we were able to retrieve the information from the dose screen 99% of the time with a 95% confidence interval. Our next step is to assign an anatomical region to the information that we have extracted. And we do this using DICOM attributes, protocol anatomy, anatomy map definition, the number of acquisitions and table position, and we were able, by manually checking, we were able to appropriately assign the correct anatomic region 94% of the time with a 95% confidence interval. This just shows our protocol anatomy maps, for example, chest, abdomen, pelvis, head and neck, neck and chest, abdomen, pelvis, and our decision tree for assigning anatomic region. Obviously, if there's one single acquisition protocol, that's the left decision tree. We assign all of the dose metrics to that particular region of anatomy. But if there are multiple regions of anatomy, then we follow the right-hand side of the decision tree and use table position and body parts and protocol anatomy maps to appropriately assign our dose metric to a specific region of anatomy. So let me show you an example of our anatomy map assignment. This is an exam of chest, abdomen, pelvis. For this type of exam, we would assign 33% to each, to the chest, 33% to the abdomen, and 33% to the pelvis. For a head and neck, however, we would assign 40% of the radiation metric to the head and 75% to the neck. So that's how we assign specific anatomical regions and assign the radiation dose to those specific regions. The next thing we wanted to do was look at patient size estimation for more meaningful radiation exposure metrics. And if we were able to do this, estimate patient size, then we may be able to give a patient-specific dose estimate and a size-specific dose estimate, and future assign specific radiation exposures to organs to give us organ dose, and this we would need Monte Carlo simulation and size-specific dose estimates. To automate patient size and estimate this, we looked at axial CTs, and we decided to model the patient as a cylinder of water and converted image attenuation to water equivalent diameter. Now, the limitations of this methodology are that we assume that the whole cross-section of the patient is included on the image, and this may not be the case, as I'm sure you've seen. It's problematic for large patients who are truncated by the field of view. What we do, though, is essentially model the patient as a cylinder of water and use water equivalent diameter. Here are the equations that we use, again, to estimate patient size. What we did to validate our algorithm was compare this against an accepted method that was created by the American Association of Physicists in Medicine, their task group 204, where they looked at effective diameter, and they looked at the AP and lateral diameters to estimate patient size. Again, we're using approximating the patient as a cylinder of water and looking at a water equivalent diameter, and the equation is shown there in blue. And then we validated our algorithm by comparing our metric against the effective diameter of the AAPM, and we did this at specific slice locations at anatomical landmarks such as the apex of the lung, the carina, the top of the iliac crest, and so on. And we found an excellent correlation using a linear regression model between the AAPM Task Force 204 effective diameter and our method of water equivalent diameter when we used water phantoms. When we looked at actual patient data, we found excellent correlation for CT abdomen and pelvis between the AAPM 204 and our method of water equivalent, and a little less accurate between CT thorax, however. So what we've been able to do is automatically extract CT dose information, CTD eyeball and DLP, from existing records in our electronic medical record using optical character recognition. We assign what we think is the best assignment of body part, and then we try to measure patient size or get an estimate for patient size to give the most meaningful information that we can about what a patient has received in terms of dose. What do we do with this information? Well, we've stored all of this extracted data in a data warehouse, and we've also configured some business analytics tools that enable us to examine all of this data, sorting by multiple parameters, including across our multiple institutions, across different body parts, different protocols, different scanner makes and models, by CT technologists, by different times of day and date and time. And it has allowed us to visualize this information at a variety of scales and identify outliers and identify trends in the way we are imaging patients using computed tomography, and then to go forward and standardize our protocols. So I'll show you some examples here. This is a screen capture of our business analytic tool to examine dose, and you can see a variety of things that we can sort on, again, across different institutions, by a particular protocol or a variety of protocols, across different scanners, our technologists, different dates, and so on. And we can get a graphical visualization of this information. Here I'm looking at two different institutions, Brigham and Women's and one of our community hospitals, for looking at CT, and we can actually even drill down even further, and in the blue Excel spreadsheet below, we can select a particular imaging examination and ask to visualize those images themselves to look at the quality and see if we can correlate that with the differences in the protocol that we have used for these particular exams. We can sort by a variety of things. I'm looking at 2 months here instead of across 1 month for CT chest at one institution, and you can see there's some variation over time as well. We can sort by weight, dose event by weight, which gives us some interesting information. And in particular, I think very interesting information where we have dose event by protocol. Now, these are all similar protocols, different names, as we have found we had quite a variety of names across our scanners for really the same examination. And you can see there is variation within our imaging centers. And this enabled us to identify outliers, remove those outliers from our protocol choices on our scanners, and standardize our protocols and hopefully optimize the dose that we're giving our patients while maintaining quality of the exam. In summary, what we've done at the Brigham has been a number of activities that look at what we can do before the exam is even done, which I didn't really talk about, I'll mention briefly here. Things that we can do during and after the scan. What can we do, what have we done actually before we've been scanning patients? Well, we tried to optimize our CT protocols to reduce radiation without sacrificing the image quality, given the technologies that we have here on the ground at Brigham and Women's Hospital and our affiliates. Some of the things that we decided to do were use of automated tube current to adjust the scan to patient size, very important to do. We've been able to reduce the number of passes through anatomy where possible, in particular for dissection CT and arteriography. We've been able to optimize our dose looking at incremental decreases in mass. We've optimized our IV contrast infusions, particularly in vascular imaging. We've been able to use low KVP imaging in some of our vascular imaging as well, and implemented iterative reconstruction algorithms on scanners where this technology is available. What I have described in detail here today has been what we've done by in-house developing software tools to extract radiation exposure from our clinical scans, store these in a database, and develop analytics modules to detect protocol outliers and enable systematic review for us over time. What we have ongoing and future activities include a continuous quality assurance program. We have quarterly reviews of our CT protocols. We're constantly reviewing these and looking at whether there are unnecessary protocols that we have on our scanners. We also reduce unnecessary exam duplication by importing outside images from our CDs into our packs rather than re-imaging a patient. And in future, we hope to use this radiation dose estimation that we have as input to our computerized physician order entry for decision making at the time of ordering the examination. And in particular, we hope we can reduce unnecessary repeat CTs exams by giving decision support alerts at order entry, saying, identifying that there is a prior CT of the same body part available, and do you really want to do this examination? And perhaps replace CT with magnetic resonance imaging and ultrasound, or advise that maybe no imaging is necessary when the evidence suggests this is appropriate. So in summary, what we've done, create some automated tools to extract radiation dose for CT in particular. We've also looked at some of our nuclear medicine studies, but I've described what we've done here for CT. We store them into a database that allows us to examine in fine detail in a variety of ways to make intelligent decisions about how we can reduce dose for patients while maintaining the same appropriate quality of imaging for our patients. Thank you very much.